Hello, everyone. This is Isaac Teitelbaum. I'm pleased to join you for this Advances in CKD conference. I wish it were in person, but perhaps next year. As you can see, I've been asked to address novel uses for peritoneal dialysis. Before we dive in, I do serve on the scientific advisory board for the three companies shown here, but none of their products is relevant to today's discussion. So by way of introduction, as you all know, PD accounts for approximately 11% of all dialysis worldwide. It's used predominantly in end-stage kidney disease, to a lesser extent for AKI. There have been some other indications for which peritoneal dialysis has been examined, including congestive heart failure, hypothermia, pancreatitis, and psoriasis. I am not going to review those with you today. Rather, I'm going to focus on two really novel potential uses for peritoneal dialysis: the use of what's called liposome or liposome-supported PD, and potential use of PD in stroke. So let's begin with liposome-supported peritoneal dialysis. By way of review or introduction, what is a liposome? Well, they are spherical nanometric particles composed of a phospholipid bilayer membrane which surrounds an aqueous core. And for some time now, they've been used for delivery of drugs or genetic material. And parenthetically, not relevant to our discussion today, if you tag the liposome with a cell-specific antibody, you can actually target the delivery of the desired material to a specific cell. But we're not going to go there today. Liposomes have been evaluated as potential scavengers for toxins. By adjusting the pH of the aqueous center of the liposome, you can program it, in a sense, to trap certain molecules. For example, by acidifying the core of the liposome, basic molecules that enter the core will be protonated and trapped, facilitating the removal. So there's been some work with the intravenous administration of liposomes trying to sequester toxins or drugs such as verapamil or amitriptyline. And they're very effective. The problem is that when you administer these things IV, A, they're very difficult to eliminate from the body, and B, because of exposure to complement, they trigger what's called CARPA, a complement activation related pseudo-allergic reaction that is similar to an anaphylactic reaction and can cause cardiopulmonary distress and obviously not desirable. And this led to exploration of liposome-supported peritoneal dialysis. Remember that small molecules will diffuse freely across the peritoneum. If you introduce liposomes into the peritoneal space and they have the desired transmembrane pH gradient, they may then be able to trap certain toxic molecules. Keep in mind that these liposomes are relatively large molecules, about 8,500 angstroms. To put this in perspective, albumin, which can diffuse to a certain extent across the peritoneal membrane, is 37 angstroms. So these liposomes are more than 200 times as large. Complement molecules, which don't readily cross into the peritoneum, are around 100 angstroms. So at 8,500 angstroms, when you put these things in the peritoneal cavity, they stay in the peritoneal cavity. And as I mentioned, complement components are about 100 angstroms, don't readily enter the peritoneum, so the risk of CARPA is markedly diminished. So potential uses for liposome-assisted PD, there's been exploration for both exogenous toxins and endogenous toxins. We'll talk a little bit about each. For the exogenous, I'm going to focus on verapamil and make brief mention of some others. So let's begin by looking at LSPD for exogenous toxins. As you know, toxin overdoses are managed with supportive care, attempts at decontamination like using activated charcoal to rid or prevent further absorption of the toxin, specific antidotes if there are any, and hemodialysis. Well, hemodialysis isn't always technically feasible. if you have a molecule with a very large volume of distribution, for example, if it's protein bound, if it's very lipophilic, the availability for dialysis is limited. Furthermore, if the molecule causes hemodynamic instability, then you have difficulty performing hemodialysis. And the case in point would be verapamil, which is highly protein bound, it's lipophilic, and it causes hemodynamic instability. There's no specific antidote. It's difficult to remove. Hemodialysis is not going to be feasible. This led to investigation for the use of liposome-supported peritoneal dialysis. And here you can see the time course of removal of verapamil by LSPD in a rat model. Rats were administered a huge dose of verapamil, 50 milligrams per kilo. That's something like me taking, what, 4.5 grams of the stuff. PD or LSPD was then initiated 60 minutes later, and as you can see, the PD alone is shown in the open triangles, LSPD in the black triangles, and you can see that at 4 hours there's about 30-fold removal, and by 12 hours, 80-fold removal of verapamil with LSPD compared to conventional PD. And here you can see the effects of LSPD and PD on the hemodynamics of verapamil intoxication. The left-hand side, you see mean arterial pressure. The red dashed line shows you the baseline, and you can see that after about just an hour or so of ingestion, the mean arterial pressure has plummeted to about 75%, i.e. it's decreased by 25% of its baseline value. With PD alone shown in the green, we get some attenuation of that marked decrease in mean arterial pressure, but it's much better when we do LSPD. And as shown on the right-hand panel, you can see that as compared to the untreated, the MAP recovery time in the untreated state is 20 hours. It was no different with conventional peritoneal dialysis, but with the use of LSPD, the MAP recovery time was decreased to about 6 or 7 hours. Other toxins have been evaluated, including the list you see here, and you can read it as well as I can recite it. You can see in the accompanying bar graph that for each of these, with the potential exception of phenobarb was statistically significant. Clinically, I'm not sure, but for each of the others, there was a dramatic enhanced removal of the toxin with liposome-supported PD as compared to conventional peritoneal dialysis. Let's turn our attention from the exogenous toxins to endogenous toxins, and let's begin by discussing ammonia. We know that hyperammonemia may develop in patients with hepatic dysfunction or in certain inborn errors of urea metabolism. It can lead to altered mental status, cerebral edema. Commonly, we manage hyperammonemia with medications such as lactulose or rifaximin, and occasionally with kidney replacement therapy such as hemodialysis or continuous renal replacement therapy. What if we have a setting in which hemodialysis may not be feasible or well tolerated? The infant, the decompensated ESLD patient with hemodynamic instability, someone who already has significant cerebral edema, we're worried about osmotic shifts. Might we be able to use LSPD? Well, ammonia is lipophilic. It's a weakly basic molecule, and it may lend itself to removal in this fashion. And here you see some experimental data in rats. I would direct you specifically to the circles, which is in vivo data. And if we look at the solid circles shown at the bottom, you can see that there is very little removal with in vivo conventional peritoneal dialysis in comparison with the open circle shown above. The in vivo LSPD provided very substantial removal of ammonia. Interestingly, when this was done in the presence of human acidic fluid, which obviously would be present in the peritoneal cavity of someone with end-stage liver disease, ammonia removal was maintained, and they were able to do this in a mini pig model of end-stage liver disease, and there was no CARPA observed. So preliminary animal studies are supportive of this concept. There are a number of drugs that might be used in patients with end-stage liver disease. For example, beta blockers or pressors like epinephrine or antibiotics. And these were examined and to determine whether they would have an inhibitory effect on the efficiency of LSPD. And indeed, they all did. The important thing to note, however, is that these are small drugs ranging in size from 250, 260 to 360 Daltons. Their plasma levels are usually in the vicinity of 5 micromolar, and the drugs were used in this study at a presence of 1 millimolar, which is 200-fold higher than plasma, and the intraperitoneal levels of these drugs would be even lower than the systemic levels. So I'm not sure what it means when you have a 200-fold molar excess of the drug and it inhibits the process of LSPD. I think this would, if this ever goes any further, we'll have to look at this at more physiologic drug levels. There was a single human trial of LSPD for the removal of ammonia. It's a compound called VS01. They studied cirrhotic patients with ascites and covert hepatic encephalopathy. They did an ascending, if you will, a dose titration study using 15, 30, or 45 mils per kilo of this VS01 solution. And then they had 3 patients who received 4 consecutive doses of approximately 40 mils per kilo at intervals at 2 to 3 hours. The findings are described here. No serious adverse events or infusion associated reactions after either single or repeated doses, and supposedly significant improvement in psychometric test results and increased peritoneal fluid clearance of ammonia and metabolites while reducing plasma ammonia levels. It doesn't tell me an awful lot. I'd love to see primary data, but this is the abstract. Future studies are planned. You can see this is just from last year. I have not seen the full article in print. We have a ways to go. What about the use of liposome-supported PD for protein-bound uremic toxins? These, of course, are, by definition, toxins that are heavily protein-bound and therefore difficult to remove by dialysis. Examples of these include p-cresyl sulfate, indoxyl sulfate, and indole 3-acetic acid, 3-IAA. They're associated with infection, cardiovascular disease, and mortality. In normal physiology, they're secreted by organic ion transporters 1 and 3 in the proximal convoluted tubule. In CKD, of course, there's less GFR, there's less secretion. We don't get effective clearance of these compounds through the OATs. Might there be an alternative way to facilitate their removal? They're not well cleared by standard HD or PD because they're, by definition, very heavily protein bound. In hemo, you might be able to adjust the KOA and increase QD to try to facilitate the removal. We have no such option in PD. Might LSPD or even albumin-based PD and introduce a binder, a sink for these compounds, would that help? And here is some data. You can see in the upper panel serum levels declining, in the lower panel dialysate levels increasing for p-cresyl sulfate, indoxyl sulfate, and 3-IAA respectively. And you can see, if you look at the lower panels, where we're looking at the increase with dialysate-based treatments, that for the PCS and indoxyl sulfate, there is no difference between the use of albumin-facilitated dialysis or LSPD. Either of them markedly increased clearance compared to standard 2.5 or 4.25% peritoneal dialysis. For the 3-IAA, there was a slight difference with the albumin performing better than did the liposome-supported PD. The issue, of course, is that albumin is far more expensive than liposomes. Interestingly, we could obtain and instill liposomes at a much lower cost than we would incur with the use of albumin. So in summary for this part of the talk, liposome-supported PD has potential for the removal of both exogenous toxins and endogenous toxins such as ammonia or protein-bound uremic toxins. Let's turn our attention to the other potential novel use for peritoneal dialysis, PD in acute stroke. By way of background, and I'm on thin ice here, I freely acknowledge that my knowledge of neurophysiology leaves a lot to be desired, but this is what I've garnered from my review of the literature. L-glutamate is an excitatory neurotransmitter that is involved in numerous physiologic reactions. In the CNS, this L-glutamate is stored in synaptic vesicles, from which its release and reuptake are tightly regulated so as to maintain a very low extracellular concentration, less than 2 micromolar. In contrast, plasma glutamate is substantially higher at 40 to 100 micromolar, and glutamate concentration in brain tissue is hugely higher at 10 to 12 millimolar. So this cartoon shows you the extracellular fluid sandwiched, if you will, between the whole brain component having a huge glutamate concentration on the one hand and the plasma glutamate on the other, both of them being higher than the extracellular fluid. The reuptake of glutamate from the synaptic space is an active process that is energy dependent. Similarly, prevention of influx of glutamate from the plasma into the brain, and it's the blood-brain barrier that does that, is also energy dependent. So we have to keep glutamate sequestered in the plasma and in the brain tissue out of the synaptic space. In stroke, glutamate accumulates in the extracellular space due to energy and ion pump failure. And there's a whole cascade of things that takes place that I am not competent to discuss. I'll give you the brief outline. This plays a critical role in the propagation of ischemic brain damage in the ischemic peri-infarct zone of a stroke by a mechanism called excitotoxicity. Glutamate overload exerts toxic effects on metabolically viable tissue through sustained activation of postsynaptic receptors. This leads to a massive influx of calcium, sodium, and water into the neurons. This in turn triggers a cascade of intracellular events, including the production of reactive oxygen species, which are damaging, inflammation, uncoupling of oxidative phosphorylation, and the whole thing culminates in apoptosis and cell death. The local release of glutamate after stroke also enhances brain-to-blood efflux, leading to a transient increase in the blood concentration. And the important thing about all of this is that we have ultimately an increase in the blood concentration of glutamate, and that has been associated with disease progression in patients with acute ischemic stroke. This is well defined. So if we can lower plasma glutamate, that's the question. If we lower plasma glutamate, will that result in attenuation of the degree of injury from the stroke? And if the answer to that question is yes, can we accomplish that safely without exacerbating the degree of brain injury? So There is a molecule called the glutamate oxaloacetate transaminase. We'll call it GOT. GOT is a scavenger for glutamate. It transforms glutamate to 2-keto-glutarate and aspartate, and thereby lowers glutamate levels in the blood. And in the graph, you can see that in the control shown in the upper diamonds, after stroke, blood glutamate is high. If you administer the GOT, then you can effectively lower plasma glutamate. And this was administered 1.5 hours after stroke. When you infuse GOT and lower the plasma level of glutamate, that decreases the infarct volume and the area of edema. Infarct volume shown on the left with the GOT in the lower line and the untreated in the upper. And you can see same on the right-hand side, the edema, both of which are decreased with the scavenger. No human trials with the use of GOT. So if lowering plasma glutamate has this salutary effect on the damage after stroke, can we remove it by dialysis? Well, glutamate's a very small molecule, molecular weight 147. Remember, creatinine is 113. Glucose that we use in peritoneal dialysis is 180, so these are in between. So it's very amenable to removal by dialysis. We could do hemo, but hemo is going to have adverse effects on systemic blood pressure, adverse effect on cerebral perfusion, and it's going to entail the introduction of osmotic shifts that would be preferable to avoid in the setting of acute stroke. Hence, we're talking about peritoneal dialysis. Here is data on a rat model of stroke and the effect of peritoneal dialysis in that circumstance. PMCAO stands for permanent middle cerebral artery occlusion. If you create a middle cerebral artery occlusion, as you can see on the left-hand panel, you get a very significant increase in plasma glutamate, shown in the red. If you dialyze the creature, this is a rat model, starting at 2.5 hours after, you attenuate very significantly that increase in the plasma glutamate. And just to show, as you might expect, if you dialyze the animal against a dialysis solution that is spiked with glutamate, the plasma glutamate still goes up. And this will become important on this slide. Here we're looking at infarct volume in animals that have been subjected to permanent middle cerebral artery occlusion. So in the left-hand panel of this slide, panel D, going from left to right, we have animals, the brain, a depiction of the brain of a rat that has undergone sham operation, and the infarct volume is 0. When one creates permanent middle cerebral artery occlusion, the infarct volume goes up to about 25%. With dialysis initiated 2.5 hours after the creation of the infarct volume is cut in half. If you do dialysis spiked with glutamate, then you do not see the salutary effect. And as shown on the far right, even if you don't initiate dialysis until 5 hours, you still, at 24 hours, have a decrease in infarct size of approximately 40 to 50%. And panel E simply shows infarct volume as a function of the plasma glutamate concentration in various animals, either with or without dialysis. And you can see that there's a very nice linear relationship between the magnitude of infarct volume and the plasma glutamate concentration. What about stroke in man? Well, we're not there yet. This is a study in in the absence of stroke, but just to see whether peritoneal dialysis can remove glutamate. This is a small study out of Israel. It's only partially convincing. You can see that if you look at the lower line represents the dialysate glutamate concentration, and the upper is the blood glutamate. Blood glutamate decreased at 60 minutes, but after that there didn't appear to be much of an effect. But the dialysate glutamate did increase at 60 minutes and seemingly increase further at 180 minutes. As proof of principle, this was a less than totally satisfactory study. But there's better data. The same authors that did the study in the rat model and showed and produced the data I showed you previously on the effect of infarct size, they took 7 normal control ESRD patients and they looked at the ability of PD to lower serum glutamate and by peritoneal dialysis. And if you look on the left-hand panel, panel A, you can see that glutamate level went from 110 to approximately 60 after 4 hours. And here on the right-hand panel, you see the time-dependent accumulation of glutamate in the dialysate. And I want you to notice something. At 4 hours, even by 3 hours, the D over P, the dialysate to plasma ratio for glutamate is approaching 1. It's well over 75–80% at 3 hours. This means that if we were to do multiple exchanges of peritoneal dialysis, we should be able to significantly lower plasma glutamate. There has been one clinical trial, and I'll tell you at the outset, it's been disappointing. But this is a European clinical trial done back in 2012. It was an open, randomized, controlled study of the safety and viability to evaluate neuroprotective effect of plasma glutamate dialysis in acute ischemic stroke, conducted at this institution in Madrid. They randomized 10 patients with acute ischemic stroke, 5 not to receive peritoneal dialysis, 5 to undergo peritoneal dialysis. And the planned protocol was to do 6 exchanges of 2 liters, 1 every 4 hours, and to start within 13 hours of stroke. The bottom line is only 1 of the 5 patients actually received the full PD treatment. And that's the problem here. 1 patient had a misplaced catheter and received no PD. 3 patients had some sort of technical problem and completed only 1 to 2 exchanges. So you can tell that the results are not going to be particularly good. If you do an intention to treat analysis, the treatment group had a 46% reduction in serum glutamate within 2 hours. That was not statistically significant. However, if we exclude the patient with a misplaced catheter who got no PD and look at only the other 4, there was a significant reduction in serum glutamate. Overall, however, no change in neurological function, no change in infarct size. They do report, however, that the 1 patient who successfully underwent the full 24 hours of PD had a good neurological outcome at 3 months with what's called a Rankin score of 1. Based upon the severity of the stroke, they had anticipated that this patient would have a much worse Rankin score in the range of 3 to 5. And they say that based on the published literature, the likelihood of this good outcome occurring spontaneously was estimated at just 2%. Obviously, this is not particularly encouraging unless you're really optimistic, but it does suggest, as proof of concept, it does suggest that if we were able to initiate peritoneal dialysis successfully in people with stroke within, let's say, 6 to 12 hours, there might be some beneficial effect. Their conclusions: peritoneal dialysis appears to lower serum glutamate level in patients following acute stroke. limited by technical considerations, the ability and speed at appropriately placing the catheter, and therefore the technical challenges in performing PD. Clearly, further studies are needed to define the potential role for PD in acute stroke. Summary of this part of the talk: PD in the acute phase of stroke may be beneficial in limiting the extent of damage. We have yet to really do a good study. Conclusion for the talk as a whole: much further clinical study, capital block letters, much, is needed before implementation of PD for these conditions can be considered. Thank you very much for your attention.